All right. Hi, class. Another topic we need to talk about for pregnancy at risk is pregnancy related to or complicated by age-related concerns. And I added hyperemesis gravidarum in here just because it's not a very long topic to discuss. You should have these PowerPoint slides located in Canvas. Please follow along and take notes. Write down any questions that you may have so that you can either email me or we can discuss them in class. Typical childbearing years are ages 15 through 44 years old. Women can become pregnant anywhere from age 9, super early, all the way to 56 years old. Pregnancy carries a higher risk for morbidity and mortality at either end of the spectrum, either too young or too old. And these concerns aren't necessarily pathophysiologic changes, but related to the condition of the reproductive system. Adolescent pregnancy are our pregnant patients at 19 years of age or younger. They're more likely to experience complications like preeclampsia. Their infants are more likely to be low birth weight, premature, have higher neonatal mortality rate. The clinical manifestations of an adolescent pregnancy, they may not seek prenatal care until the 3rd trimester because they're afraid of telling people that they're pregnant, if at all. And then for various reasons resulting in various complications to the mother and the fetus. Treatment of adolescent pregnancy, of course, is prevention of pregnancy first, by practicing abstinence or educating on contraceptive methods. Determine their social network, who can help them with this pregnancy, and we'll need to consider cultural factors as well. In all adolescents, especially our pregnant ones, we need to care for their developmental needs. They don't change just because they're pregnant, but it can complicate them. And we need to take into account these needs when we're planning their care. We need to care for their physical needs, make sure they're eating well, making healthier choices, and then encouraging different contraceptive methods. We need to also care for their emotional and psychological needs. We need to be supportive of them. They're at increased risk for suicide. We need to include significant support people in their care, offer community resources, and of course, we're going to be non-judgmental and open-minded for these patients. If we aren't, that can make it so that they don't seek care. The other end of the spectrum is advanced maternal age, or AMA. That's women 35 years and up. It's also, the medical term is also called geriatric pregnancy, which is kind of rude, right? I like advanced maternal age better. These women, the advanced maternal age has increased significantly over the last few years related to fertility treatments getting better and better. Our risk factors for these women are multiple fetal pregnancies, chromosomal abnormalities. They're at higher risk for spontaneous abortion or miscarriage, preeclampsia, gestational diabetes, preterm delivery, bleeding and placental abnormalities, ectopic pregnancy, fetal demise, and cesarean delivery with low birth weight infants as well. These women are more likely to have a chronic condition, which makes them at higher risk. They may report more discomfort. If they're feeling physically fit, they're less likely to complain of tiredness and distress. Treatment, we should have a preconception visit with them with a complete physical examination before pregnancy, if possible. We offer genetic testing and counseling, specifically for trisomy 21 and 18 and 13, which are more common in our advanced maternal age patients. Nursing care, of course, we're going to be non-judgmental as we would with any other patient. answer all questions, offer information on support groups, and offer support and encourage discussions with them. And now we're on to hyperemesis gravidarum. Hyperemesis gravidarum, that's how you pronounce it. I've heard it pronounced many different ways, but it is gravidarum. Clinical manifestations are severe nausea and vomiting, dehydration, weight loss, because they're vomiting so much, right? Electrolyte imbalance from the vomiting, specifically hypokalemia, and acid-base imbalances. Risks increase with multiple gestation pregnancies. So more babies you have, the more HCG you produce, which makes you more at risk for nausea, severe nausea and vomiting, or hyperemesis gravidarum. Molar pregnancy or a history of hyperemesis gravidarum. Treatment, we try non-pharmacological treatment first in all pregnancies for anything, right? We want to try no meds first, but if that doesn't help and they continue to be severely nauseated and vomiting, they may need to be hospitalized for dehydration, for medication, and we need to come up with a diet plan for different triggers of foods to avoid certain foods that may cause more. Our nursing care, we're going to assess and document, decrease their trigger factors, assist with regaining fluid balance, obtain nutrition needed, encourage good oral hygiene, especially after vomiting, and observe family dynamics. Some of these patients will need a Zofran drip in the hospital and maybe even a Zofran pump at home if it's that severe, or other medications that the provider will prescribe. Earlier in pregnancy, it is common to have nausea and vomiting, but this is severe nausea and vomiting in pregnancy, hyperemesis gravidarum. That concludes our lecture. I will see you all in class. Please let me know if you have questions.